This conference will now be recorded.
Great. And with that, I'd like to turn over the forum to Ruth Davis, the co-chair for the St. Lucie County Diabetes Coalition, to kick this forum off.
Good morning, good morning, good morning, everyone. Before I start, I would like to start with a word of prayer. Let us pray. Oh, eternal Father, we are thankful for this day, for this is the beautiful day that you have made, and we are rejoicing in it. We thank every participant that's joining us today. We thank you for our virtual diabetes forum. Father God, we pray that it will be a blessing to each one and they will be able to take something back to their community. We pray, and oh Father God, when everything's said and done, we're going to give you the glory that you deserve for all the things that you do. In Jesus' name we pray. Amen and amen. Now, I'm going to give you a little history on the Diabetes Coalition. The St. Lucie County Diabetes Coalition was organized December the 17th, 1998. A coalition that's 23 years old in existence. Some of our founding members are deceased and have gone on to glory, but we still have some founding members that are present. Just to name a few, we have Malin Krusky, Florence Hute, and myself that are still active in the St. Lucie County Diabetes Coalition. Our mission and our purpose is to address the community needs related to diabetic prevention and care. The coalition has many goals, but our main goal is to assess the health needs of the community and recommend and monitor a coherent plan for continued and ongoing improvements in prevention, detection, as well as treatment of diabetes for all citizens of St. Lucie County. November is National Diabetes Prevention Month. The Diabetes Coalition chose to host a forum during this very important month to raise awareness about diabetes in St. Lucie County and some unique challenges some of our residents have faced managing their diabetes during the pandemic, and how a variety of professional disciplines can support diabetes during these trying times. We hope this forum provides you with some tools you can take back to your practice and will arouse a passion in you to not only help your clients manage diabetes more effectively, but join our efforts to prevent diabetes as well. It gives me honor to introduce this first speaker. His name, Edgar Morales. To kick off the forum, I am pleased to introduce Edgar Morales with the Florida Department of Health in St. Lucie County. Edgar has been with the Florida Department of Health since 1991, and during this time has filled many positions in various departments, from environmental health to epidemiology. And from 2005 until the present, he has been working in strategic planning and quality improvement. Edgar stays on top of local, state, and national data to help drive Department of Health programs and improvement projects. Most recently, he has been working with a quality improvement team to increase identification of tobacco users in their clinic and electronic referrals to Tobacco-Free Florida, Tobacco Cessation Services. Today, Edgar will present the latest diabetes data in our community and highlight some of the disparities that have been identified. I present to you none other than Mr. Edgar Morales. Edgar.
Well, thank you, Ruth, for a very kind introduction. My name is Edgar Morales, and I work for the Florida Department of Health with offices here in St. Lucie County. And the purpose of my presentation is to provide you with a sense of how the burden of diabetes and health inequities have affected St. Lucie County. So the purpose of my presentation here today is to provide you with information on the prevalence of diabetes, some estimated costs of diabetes, the trends in death, hospitalizations, and amputations, and again, some of the health inequities that we find within the community in terms of diabetes. The next slide shows or demonstrates the national trend for people who are diagnosed with diabetes, people who are 18 years of age and older. And as you can see, this trend is on the increase, and this is a national trend for newly diagnosed diabetes in adults. This trend will continue to increase. We don't see anything that will stop this trend. But today, I'm hoping that the information that we provide will inspire medical providers to create initiatives and to provide some insight and wisdom on how we can better prepare our population and prevent diabetes. The next slide. Diabetes in St. Lucie County is actually the 6th leading cause of death. And that is behind cancer, heart disease, unintentional injury, stroke, and chronic lower respiratory disease. So diabetes is the 6th leading cause of death in St. Lucie County. In the next slide, I would like to present to you the prevalence for people who suffer from diabetes, people who are 18 years of age and older. The estimated prevalence of diabetes in St. Lucie County is around 12.2%. And we can compare that with Florida. The average in Florida is 11.7%. So the levels that you see underneath 12.2% are the levels that we could find within the community. So the prevalence could be as high as 15% for adults who are 18 years of age and older. The next, on this slide, I also present that the main risk factors for diabetes are obesity and lack of physical activity. The data that I'm presenting here is from the Florida Behavioral Risk Factor Surveillance System. which is a telephone survey conducted by the Centers for Disease Control and Prevention, together and with joint efforts with the Florida Department of Health and the Division of Community Health Promotion. This is a scientific survey that is produced every single year. So it is the data that we receive from this survey helps monitor the prevalence in the county. Next slide. Here I present some data from the Census Bureau and the American Community Survey. And what you can see here is the total population for St. Lucie County in 2019. This is the estimate. The estimated total population was close to 313,000 people. However, when we break this down by age distribution, we can see that 80% of the population in St. Lucie County, 80% are people who are 18 years of age and older. And the number for that population of 18 years and over is around, it's a little over 250,000 people. And you can see on the right of this slide, the age distribution of 18 and older. Next slide. On the next slide, I'm going to, these census, this data that we find from the Census Bureau and from the American Community Survey are actual 5-year estimates. And the reason why I present 5-year estimates is because that data gives us a more statistical reliability, a better statistical reliability for less populated areas in the U.S. and particularly within the county jurisdiction. So that's why it's important to indicate 5-year estimates. The next slide, again, I present on this slide the total number of adults, I'm sorry, the total population in the county, close to 313,000. And those who are adults, 18 years of age and older, are 250,000. So what that means is, given on the next slide, if we can move the next slide, given that we have a prevalence of 12.2% of adults who have diabetes, then we can calculate the number of diabetic people within the county with an estimated, within the estimate. So the estimated number of people who have diabetes, adults who have diabetes, is around 30,000 people, a little over actually 30,532 individuals. That's a big number. So on the next slide, what I'd like to present to you is the cost of diabetes in Florida. The average cost of diabetes in Florida in 2017 for adults who are 18 years of age and older. This estimate comes from the American Diabetes Association and its journal called Diabetes Care. It is they published an article known as the economic cost of diabetes in the U.S. And we're giving you some links to that article. It's the link is appears in the chat box, so you can actually download that article and read it. It's very technical, but it gives you a sense of the economic cost in the U.S. The article also comes with a supplementary data, and within the supplementary data, we can find the economic cost for every single state. So the numbers that you see here in this slide is the estimated cost in 2017, the estimated cost of diabetes for adults in Florida. So the medical cost, for example, is close to $10,000 in 2017 prices, cost prices. The indirect number or the indirect cost is around $3,000. So the total cost of diabetes in Florida, the average is about $13,000. Now, if we bring that to the county level, that average to the county level, I would like to present to you the estimated cost of diabetes in St. Lucie County in the next slide. So the estimated cost of diabetes in 2017 cost prices, given the prevalence rate of 12.2 and the number of people of 30,532 individuals in St. Lucie County who are diabetics, that is adults who are diabetics, the medical cost is around $303 million. These prices are in the millions. And again, the cost is based on 2017 prices. $303 million for medical costs and $86 million in indirect cost. Now, the indirect cost, let me go back to the medical cost. The medical cost is direct medical cost to an individual.
I was trying to get
the indirect cost is related to absenteeism in the workplace, loss of productivity, reduced productivity while at work, and those individuals who are not able to be in the labor force and are able to work or are disabled and are of the age, are part of the labor force by age. So because of disability and disease-related disabilities, we have an indirect cost of close to $90 million, giving us a total cost for St. Lucie County of $390 million. So that's a very high cost for only one disease. And again, this is extrapolated from the article, the economic cost in the US, which gives us average cost by state. Again, given the fact that the prevalence rate in our county could be as high as 15%, these are just moderate costs given a prevalence rate of 12.2%. The next slide. In the next series of slides, I'd like to present to you the trend of diabetes. Here, I'd like to begin by presenting percent of people being told they have pre-diabetes. And again, this data comes from the same survey, the Behavioral Risk Factor Surveillance Survey, which is done every single year in the state of Florida. And as you can see, this trend keeps going up. The percent of people being told they have pre-diabetes continues to increase from 2013 to 2016 and finally to 2019. And we have a comparison here, a comparison with Florida. The next slide, please. On the next slide, we present the age-adjusted death rate per 100,000 people within the county. And these are numbers, official numbers from 2019. We give you the age-adjusted rating or rates because this is a way to make fair comparisons between groups with different age distributions. So for example, a county that has a higher percentage of individuals who are elderly, we would expect them to have a higher rate of death or higher rate of hospitalizations. So by adjusting the age groups and adjusting by distribution of age, we can have a better comparison. It's fairer. As you can see here, the Black population within our county is greatly affected from diabetes. When we look at the age-adjusted diabetes numbers are also higher than Florida. You can also see that males are greatly affected compared to females within the county. Our next slide. On the next slide, I'd like to present to you how diabetes affects the years of potential life lost under the age of 75. Now, the years of potential loss of life lost is a measure for premature mortality, which is simply the sum of the years of life lost annually by persons who suffered early death before they reached the age of 75. So as you can see again, the Black population is greatly affected, and our numbers are much higher than Florida. So are males. Let's go to the next slide. The next slide, I present to you a trend line for age-adjusted three-year rolling diabetes death rates. And here you can see that St. Lucie County is outpacing Florida exponentially. So if we don't do anything, if we don't have any interventions community-wide, we will continue to outpace and greatly increase compared to the rest of Florida. The St. Lucie number here is 23 compared to Florida, 20.3%. But I want to show you that the trend line is really alarming. On the next slide, we also present this the data about death from diabetes, but on a single year basis. From 2015 to 2019, we see that the trend is still the same. It outpaces Florida, and it will continue to do so if we don't do anything about it. On the next slide, I would like to present to you the ratio, the difference between blacks and whites in terms of ratio for age-adjusted death rates from diabetes. And this is by race. So you can see that the red line demonstrates that blacks in St. Lucie County are 3 times likely to die from diabetes compared to whites. So here we demonstrate a health inequity within the disease and within our county. On the next slide, I'd like to present to you the 3-year rolling age-adjusted death from diabetes, and this is broken by race as well. And again, you can see that blacks, the inequity in the black population compared to the white population. And I'd like to present to you also that there is a comparison here between blacks in St. Lucie County and blacks in Florida. And blacks in St. Lucie County are outpacing the average rate within the state of Florida. So that's also alarming. Let's continue to the next slide. The next slide presents a 20-year trend for preventable hospitalizations under the age of 65 from diabetes. So this graph shows this trend of 20 years. The measure is an indicator that demonstrates the importance of preventing hospitalizations from ambulatory care sensitive conditions, for which hospital admission could be prevented by interventions in primary care. This measure is the number of hospitalizations due to diabetes for a specified age group. So let's go to the next slide. And the detail on that measure for hospitalization, you can see the trend line. It outpaces Florida, and it will continue to outpace Florida if there's no intervention whatsoever within the community. On the next slide, I'd like to present to you another way of looking at hospitalizations, but this time is for people who are hospitalized from diabetes or with diabetes. So here again, we see that our numbers are outpacing Florida, and the trend will continue to increase. Let's continue on to the next slide. That trend line that I just showed you, now it's in single year, not in rolling rates, but in single years, we see that the ratio of Black to white in terms of hospitalizations from or with diabetes is 2.25 Blacks compared to whites. So 2.25 times, the ratio is 2.25 times greater in the Black population within St. Lucie County. Let's continue to the next slide. This presents the age-adjusted hospitalizations from amputations of lower extremity that are attributable to diabetes. This is a 20-year rolling, a 20-year trend line. And in the detail, on the next slide, you see that if we continue this trend for hospitalizations from amputations or of lower extremities, will continue to outpace Florida. We will be outpacing Florida in the near future, and it will greatly increase if nothing is done. Let's continue to look at the next slide. The ratio, again, between Blacks to whites in terms of amputations is 3 to 1. So the Black population is feeling the brunt of amputations due to diabetes. Let's move to the next slide. Finally, I'd like to present to you the last table here, which presents adults with diabetes who had an annual eye exam. And the rate here is about 74.6% compares to 69.7%. I see this as a positive trend. More people who are diabetics receive annual eye exams compared to Florida. And we need to continue to, perhaps this is I would say, something that maybe the coalition has greatly emphasized in people who are diabetics, that they need to get an annual eye exam, and this is something that is preventable. But again, it also shows the magnitude of people who with diabetes who do need an eye exam. So you can see it both ways. It could be negative or it could be positive. On my last slide, I would like to make a call to action. And the call to action is that diabetes will continue to increase over time. 30,000 plus people have diabetes in our county, and the numbers will continue to increase. The mortality and the morbidity, the disease and death caused by diabetes is very high. It will continue to increase if nothing is done. It's right now around $400 million in St. Lucie County. And that is a cost that it's a burden that it's upon the population of in St. Lucie County. So I call medical providers to consider prevention and treatment interventions and resources that address the burden of diabetes in St. Lucie County. And at this time, I would like to entertain any questions that you may have. I put the links of the Florida charts in the chat box, and also the links, and thanks to Emily, she put those links together in the chat box. The supplementary data with the costs of diabetes, and together with the article, the research article from the American Diabetes Association.
Thank you, Edgar. for sharing the data with us. I know that this data will help drive new projects and partnerships in the coming year to tackle diabetes in our community. Thank you. At this time, I will introduce speaker number 2, which is Dr. Paul Graham. Dr. Graham was born in Coates, Texas, and raised in Portland, Oregon from the age of 5. He attended college at the University of Oregon, Eugene, where he earned a BS degree in psychology in 1976. He graduated from the University of Rochester School of Medicine and Dentistry, Rochester, New York in 1980. He did his residency in internal medicine from 1980 to 83 and fellowship in endocrinology from 1985 to 87 at Wilford Hall, USAM Medical Center, Lackland Air Force Base, San Antonio, Texas. He was stationed at Davis-Monthan Air Force Base, Tucson, Arizona, from 1983 to 85, and Kessler Air Force Base, Biloxi, Mississippi, from 1987 to 89. After an honorable discharge from the Air Force with the rank of major, he moved to Vero Beach, Florida in 1989 and joined the doctor's clinic. He was there until 2001 when the clinic closed. He is currently a founding member and partner of Diabetes and Endocrine Associates of the Treasure Coast since 2001. He specializes in diabetes, thyroid, osteoporosis, adrenal and pituitary disorders, and is board certified by the American College of Endocrinology. He's a member of Phi Beta Sigma fraternity. Please join me in welcoming my friend, my special friend, my loyalty friend. I have to say, no matter when we organize the health fairs in the community, Dr. Graham would always say yes. And I appreciate him for that. So join me in welcoming Dr. Paul Graham. Dr. Graham?
Yes, thank you, Ruth. Thank you very much. I appreciate it. Can everybody hear me okay? Can you hear me? You can hear me? Okay, good.
Yes.
I had a little technical problem with my computer, and anyway, if it's straightened out, you can hear me. If there's a problem with the audio, please let me know. You know, give me a hand sign or something. Okay. First of all, I want to thank Ruth for that wonderful introduction, and I want to thank her and Jennifer Harris and all the other folks that have helped put this nice program together. I'm a member of Phi Beta Sigma fraternity, which you can see by my shirt here, Phi Beta Sigma. This is one of our community projects that we do every year. We try to participate either in a health fair or some other type of program emphasizing either diabetes or some other kind of medical situation. So some of my frat brothers may be listening to this as well. And so we want to thank Ruth for putting this together. She makes it easy for me because I just show up and speak, and Ruth does all the coordinating and all the background. And she has lots of contacts, especially at the health department. So I appreciate Ruth very much. So I do have to give accolades to the folks that put this slide set together. This is actually, I borrowed this from Florida State College of Medicine. Juliet Lomax Homier is the dean of the local satellite in Fort Pierce of FSU. And some of the doctors' names are mentioned at the bottom there. that helped put this slide set together. It's very nice. Next slide. So we're going to talk about diabetes, and I'm going to take about 30 minutes or so, and certainly happy to answer any questions and bring diabetes into focus. Next slide. It's nice to do a patient presentation because it's, we can all relate to it, and it gives you a hanger to hang your clothes on, so to speak. And this is Mrs. Sugar, which is an appropriate name. She's an obese 45-year-old female, comes in for an annual physical. She had not seen a primary care doctor for over 5 years. She's seen her gynecologist yearly and gets her pap smear breast exam. She's usually good about that. And she's scheduled for a colonoscopy next month. She does not watch her diet, as you will see here in a minute what her weight is. She does walk her dog for about 15 minutes a day, but that's the only exercise she gets. She goes to the ophthalmologist once a year and sees her dentist every 6 months, so she's good about that. There's no complaints of any chest pain, shortness of breath, or any other complaints, actually, no polyuria, polydipsia. And you can see from her past medical history is pretty negative, except for appendectomy. And it looks like she is single, no children, and has one little dog that she walks daily. Next slide. These are her vital signs. Her blood pressure is a little high, as you can see, 140/85. As you know, we prefer 120/80 would be ideal. Heart rate, respirations. Her weight is up a bit at 300. You can see she's pretty tall, 5'11" for a woman, but still that weight of 300 pounds is high, and her BMI is 41. For her height, her weight should be more like maybe 160, 170, somewhere in that range. Her physical exam is pretty normal. As you can scan down the slide there, you can see things are pretty straightforward on her physical. Next slide. So our assessment on this, just an annual physical, is that she's got elevated blood pressure, of course, and they'll treat and take care of that. Her weight is high, and the doctor ordered some lab studies to get done. And next slide. You can see on the labs, they come back a week later. Apparently she had a follow-up appointment after her labs were done. And this is a fasting blood sugar of 146. As you know, normal fasting blood sugar is about 100. Her creatinine is good, BUN is fine, GFR is fine. Her LDL cholesterol is a little high at 115. As you know, normal is less than 100. Triglycerides are good. Her A1C was 7. Now, this is a woman that has no previous history of diabetes. So as you know, the A1C should be less than 6. At Quest Lab, it's usually less than 5.7, roughly. So she's got new onset diabetes, but no symptoms, no complaints of any polyuria, polydipsia, things like that. So it's a good thing she went to get this routine physical, because diabetes is like hypertension, can be one of those silent killers. Next slide. So now we have a lady that's overweight with new onset diabetes, and how do we treat it? Well, metformin, and we'll talk about why that is in just a minute. Also, her blood pressure is high, and so lisinopril is a good choice. We like the ACE inhibitors because they're friendly to the kidneys. So that'll help her kidneys as well as her blood pressure. And then for cholesterol, we like the statins. You know, Crestor is the newest of the bunch of the statins, which is rosuvastatin, 5 milligrams once a day. And that should get her in ship shape in terms of the cholesterol. Next slide. So escalating therapy, you know, we start with diet, exercise, weight loss, of course. We always send everybody to the dietitian or to a diabetes educator. Bridget Broxton, my good friend, will talk to you a little later about diet, exercise, and weight loss. She's a ARNP and also a certified diabetes educator. So if you have a CDE in your area, certainly take advantage of them. They're usually either registered nurses or they're registered dietitians that take extra training in terms of diabetes care and treatment. So definitely I send everybody to the dietitian or a CDE, and then encourage them to start exercising and put them on metformin. All right. STEPS therapy, and STEPS is a acronym for, this is brought up by Dr. Steinberg, which is referenced here in just a bit. The acronym STEPS stands for safety, tolerability, effectiveness, price, and simplicity. When you're deciding what diabetes medicines to choose after metformin, we always start with metformin. So we'll talk a little bit about what this steps therapy helps you choose the second, third drug and how to progress on. We start with metformin because it's been around for a long time. It's a very safe medicine. The only thing you have to watch out for is, as you know, lactic acidosis, and that only occurs in rare situations where their creatinine is elevated above like 1.5 to 2, and their estimated GFR is less than 30. So as long as you watch their kidney function, lactic acidosis is extremely rare. We don't see it very often. Also, if a patient has a CAT scan with contrast, MRI, any kind of contrast material, we always stop the metformin for a couple of days before and then hydrate and check the creatinine afterwards. So as long as you keep in mind those precautions, metformin is very safe. About 20% of folks on metformin can develop stomach upset, little GI upset, diarrhea. And in those cases, I usually switch to metformin ER or extended release metformin. I would always give that a try. It's coated, it's a coated form of metformin. It used to be called glucovance, and glucovance became generic. And so now it's just metformin ER or XL. And that usually works. And that 20% of patients with stomach upset with plain metformin, in my experience, it usually works about 80–90% of the time. So you can press on with that. And it's generic and it's cheap. All right. Actually, it's free at Publix. Next slide. So most patients with diabetes will require 2 medications or more. It's hard to control them just with one. And it all depends on how early you catch them in the natural history of the disease. It's just like high blood pressure. You know, if someone comes in with a high blood pressure of, 180/100, you're not going to get by with one medication. You're going to have to put them on an ACE inhibitor and a diuretic or a beta blocker. One medicine's not going to do it. Same is true with diabetes, that many times you're going to need more than just metformin to control it. So that's where the steps therapy comes into mind as to what do we pick next. Next slide. So this is a list of the different diabetes medicines. If someone comes back 3 to 4 months later, you check their A1C and they're out of range. ADA recommends an A1C less than 7. ACE, the American College of Endocrinology, recommends an A1C less than 6.5. And so she was already at 7, so we'll shoot for 6.5. So she's on metformin. Let's say she comes back 3 or 4 months later and her A1C is still not at goal. What do you take next? Well, if I gave this talk 20 years ago, which I have, we would probably pick a sulfonylurea like glyburide or glipizide or Amaryl, which is glimepiride. We've kind of shied away from those over the past several years because of the risk of hypoglycemia with the sulfonylureas. So there are better, newer choices now. The GLP-1s are an excellent choice. Like, for example, Bydureon, Ozempic, Trulicity, Victoza. You see those brand names advertised quite a bit. The DPP-4 inhibitors are things like Januvia, Tradjenta. Well, we don't like those as much. They're pills, which is nice, but they're not as potent as the GLP-1 injections. The Bydureon and Ozempic are given by injection. It's an auto-injector, and it's given once a week. Just weekly, not daily, but just once a week injection. They stimulate the pancreas to make insulin, they delay gastric emptying, they suppress appetite, and they do multiple different things to help control the blood sugar. They're 3 times more potent than the DPP-4 inhibitors like Januvia. The DPP-4 inhibitors block the breakdown of GLP-1. So they basically do the same thing as the GLP-1 agonist, but they're just not as potent. And so yeah, that's why, even though it's a pill, we kind of prefer the injectables. They're more potent. Okay, you get more weight loss. The new kids on the block are the SGLT2 inhibitors, sodium glucose transport inhibitors, the medicines like Farxiga, Jardiance, Invokana, you see advertised quite a bit. Those medicines have multiple advantages of not only lowering the blood sugar, but also they help the heart, decrease the risk of congestive heart failure, and they also decrease the risk of chronic kidney disease. They slow the progression of chronic kidney disease. They work by kind of a unique mechanism. I always tell patients the kidneys are like a filter, and the kidneys filter your blood, and they get rid of the bad stuff like creatinine and hold on to the good stuff like nutrients and proteins and glucose. The problem in diabetics, the kidneys hold on to too much sugar, and it's part of the reason why your blood sugar is high. By these blocking those enzymes in the kidneys, it causes more sugar to spill out in the urine. So every time you urinate out an extra 300 calories of sugar. It's like 70 grams or more. It's about 300 calories per day just by taking the pill. So by urinating out more sugar, of course, it lowers your blood sugar, but also it lowers your blood pressure and does some other things to help your heart and kidneys. So the SGLT2 inhibitors have become more popular over the past few years because they have multiple advantages. The TZDs are kind of gone by the wayside. That's Actos or pioglitazone. It's a good medicine. They're sensitizers mostly, and they do work. They're generic, they're cheap. The problem is they can cause fluid retention, and for patients prone to heart disease, CHF, it can worsen CHF or bring it on. Also, there's been some risk of concerns about people that smoke. There's an increased risk of bladder cancer in these medicines, and so for those, we've kind of shied away from those. Again, they can be used in certain situations, just like the sulfonylureas, because they are cheap, inexpensive, and patients that are self-pay, no insurance, we kind of lean toward those because they can't afford some of the newer meds. But there are some precautions. You have to be careful. Obviously, if the patient's A1C is over 9, that you're going to have to consider insulin. Next slide. So factors contributing to worsening hyperglycemia, the most important factor is food. So I always tell patients, you are what you eat and how much, which is what my mom used to tell me. So if you eat too much, you're going to be fat. I'm sorry, I can't change, the laws of nature. When patients that weigh 300 pounds tell me they don't eat that much, well, their perception is that they don't eat that much. That's their perception. But the reality, if you have them keep a diet diary, is that they eat too much. That's why they're 300 pounds. And so that's why the dietitian is really critical, to get them on a good diet plan, less than, 1,600 calories a day, exercise. And so you want to make sure the patient's doing those basics in terms of getting their weight down. Also, always double check about illness. Sometimes the patients are sick with a cold or flu or other things that'll run the sugar up. You have to question them about glucocorticoids. Sometimes patients are on prednisone, Medrol dose pack for various reasons. They may have gone to the orthopedist and had an injection in their knees or shoulders, with steroids that can run the sugars up. And so you have to ask a few basic questions just to be sure, why their blood sugar is running high. And also compliance, obviously. Are you taking your medicines appropriately? Next slide. And so the steps therapy, we know that metformin's first line. The question is, what do you take after that? Keeping in consideration the risk of hypoglycemia, some other comorbidities, other medical problems that patients could have. Effectiveness price is always an issue with a lot of patients, especially if they're self-pay. Next slide. And then for long-term therapy, again, checking compliance, lifestyle changes, things like that. Next slide. So efficacy and side effects, when you're trying to get that A1C down, the best combination, I think, is to start with metformin, and if you have to add something, is add a GLP-1 agonist like Bydureon, Ozempic, Trulicity, Victoza. Now, Victoza is an injectable you give once a day. The other ones are once a week, and some of them have auto injectors, or other ones like Ozempic is given just like insulin, but it's only a once a week injection. And again, we prefer those over the DPP-4 inhibitors like Januvia and Tradjenta because they do the same thing. They both work by the GLP-1 mechanism. It's just the injectables are 3 times more potent. And so we kind of lean toward those. If weight is an issue, be careful about the thiazolidinediones, which is pioglitazone or TZDs, pioglitazone or Actos. Can cause weight gain, fluid retention, and so you just have to be a little careful if you're trying to help people lose weight. Sulfonylureas also can cause weight gain as well as insulin and some hypoglycemia. If you want to emphasize weight loss, which is 80% of patients with type 2 diabetes are overweight, and most of them need to lose weight, like this lady, then the GLP-1s are really helpful because they do suppress appetite, delay gastric emptying, so you fill up faster when you eat, and so people feel full and they usually stop. The average patient on a GLP-1 like Bydureon will lose about 5 to 10 pounds over a few months. Also, the SGLT2 inhibitors like Farxiga, Jardiance, they also can cause weight loss of about 5 to 10 pounds over a few months. Metformin causes a slight weight loss, maybe a few pounds, but not that much. But the combination of these three are the combination that's going to give you the most weight loss. Again, the DPP-4s are more neutral in terms of weight. Hypoglycemia, the sulfonylureas, insulin are the main things that do that. Next slide. So you also have to kind of pick agents based on the comorbidities. What other medical problems does the patient have? Do they have a lot of atherosclerotic cardiovascular disease, heart disease? Do they have CHF? You know, HFrEF is heart failure with reduced ejection fraction. And the SGLT2s have been shown to be very effective in reducing the hospitalization due to heart failure. The chronic kidney disease, which is very common in diabetes, the SGLT2 inhibitors, and to some extent the GLP-1s do help the kidneys. Weight loss is mainly from GLP-1 and SGLT2s. But if cost is an issue, the sulfonylureas and TZDs are still used, and they're good medicines with the proper precautions. Next slide. Now, this is a very complicated slide that I think I'm going to skip because it's hard to read and it's really better as a handout. So I'm going to ask you to take a picture with your cell phone or talk to Jennifer a little later, and maybe she can get a copy of this for you printed out, because it's a great handout to have, but it's not a great slide. There's too much stuff on it. Next slide. I would not have made the slide. So you need to reevaluate patients every 3 months, and sometimes if they're under control, you can start having them come back every 6 months. Most of their A1C is a goal. But generally every 3 months, have them check their blood sugars, send them in. I have patients get a meter, do finger sticks, and send the readings to us and come back and see us in 3 months so we can get them under control. Next slide. So if you have a patient on 2 or 3 oral agents or injectables like Bydureon and Ozempic, and you still don't have them under control, which happens occasionally in type 2 diabetes, then the next move is to insulin. We usually add insulin to that regimen. If you've got them on metformin, say Bydureon, Farxiga, and their A1C still not a go, we'll add 1 shot a day of basal insulin to help get them down. Why does that happen? It's usually because the beta cells are kind of burnt out. It typically more happens in a patient that have had diabetes a long time, you know, for 10, 15, 20 years, and they lose beta cells with time. Occasionally it happens in a patient with new onset diabetes that they've just had it a long time, the beta cells are burnt out. And so you need to put them on insulin to let the beta cells rest, and then you can sometimes transition them back to oral agents. We have that happen in the hospital once in a while, where patients come in with a blood sugar 400 or 500 and A1C is 13%. And so we'll put them on insulin right away to let the beta cells rest. We don't even put them on any oral agents. And tell the patients after about a month or so, we'll see if we can start metformin and some other things and transition them off the insulin. And that happens too. Insulin is your friend. It's been around for a long time. It came out in the 1920s. Some of you probably remember Banting and Best discovered insulin in the 20s and won a Nobel Peace Prize for the discovery of insulin. They isolated from animals, mostly pigs and cows, and injected it into humans. And at that time, diabetes was a scourge. And if you had a diagnosis of diabetes in the 1920s, you were going to die. It's almost like when HIV first came out, nobody wanted to know I had HIV. So you're going to die. And so it was like a big secret. In the 1920s, without insulin, you were dead. So when insulin was discovered, it saved millions of lives. And so insulin is a miracle drug. And I always try to encourage patients that it's not a negative, it's a positive. Thank God we have it. Next slide. And so there's different forms of insulin: quick, short acting, intermediate acting, and then of course long acting, and some combos. They break this down at the top with rapid acting insulins such as Novolog, Apidra, Humalog, or the quick short acting insulin. They usually work within 10 to 15 minutes after you give the shot, and they peak an hour and a half and go away in about 3 or 4 hours. The short acting, which is regular, the older generic insulins like Humulin-R, Novolin-R, they work a little more slowly. The onset is about 20 to 30 minutes. So I usually have patients give the shot about 30 minutes before the meal. It peaks in about 4 hours and goes away a little shortly thereafter. The intermediate is NPH, and NPH I usually give at bedtime if we use that because it works overnight, lasts for peaks in about 4 hours, which would be the next morning, and lasts up to about 16 hours. The more popular long-acting basal insulins are Lantus and Levemir, and actually the newer versions of those you've heard of Toujeo and Tresiba, which even have a longer half-life. You notice under peak, they're peakless. And so they kind of get to a certain level and then they're flatlined. So they don't tend to peak, and they're great medicines, insulins to take at bedtime. Some people take them in the morning. I prefer it at bedtime because you can use a fasting sugar in the morning to kind of titrate the dose. We kind of start with 10 to 20 units at night and then titrate the dose to get that morning blood sugar about 120 or so. Some patients with type 2 diabetes will use the premix 70-30 insulin or 50-50 or 75-25. That's just so you only have to take 2 shots a day instead of 3 or 4. Typically with basal insulins, we'll start at bedtime and get the morning sugar down, but if they're not under control, they might need a pre-meal shot of a quick-acting regular or Humalog, Novolog before meals. So now you're up to 4 shots a day. It gets to be a little cumbersome for some patients, especially with type 2 diabetes. Type 1, they really need to be on 3 or 4 shots a day because they're more brittle. But patients with type 2 generally don't need 4 shots a day. So they came up with the premix, which is a mixture of 70% NPH and 30% regular. So they get both intermediate and short acting in 1 shot. When you take the shot at breakfast time, the quick acting regular works from breakfast to lunch and keeps your sugar down at lunch. The longer acting NPH carries you over to dinner time. And then you take a second shot at dinner, and the quick acting regular covers dinner to keep the sugar down. And then the NPH works overnight to keep your blood sugar down the next morning. So you basically take 2 shots, but you get the benefit of like 4 shots. Next slide. So this just shows insulin activity. Again, the rapid acting like Novolog, Humalog tend to work very quickly. I tell patients, if you're going to take a shot of Novolog or Humalog, you need to have dinner ready because, you check your blood, take your shot, and you eat within 10, 15 minutes. The regular, you got to time it a little bit more because it doesn't kick in for about 30 minutes. The intermediate acting is NPH, and of course, the long acting Lantus, Levemir, are kind of the peakless insulins. Next slide. And so, how do we choose? Well, we always start, if a patient's on combination therapy, if they're on metformin and a couple of oral agents or an injectable GLP-1 like Bydureon once a week and they're not under control, I usually add a basal insulin at bedtime. I'll start with like Lantus or Levemir or Tresiba or Toujeo. And I usually start with about 10 to 20 units once a day at night to bring the morning blood sugar down to about 120. And I have patients self-titrate that to keep that blood sugar where it needs to be. And if over time you can get the A1C down less than 7, then you're good. If you can't, then you need to add a pre-meal insulin, like a little bit of Novolog or Humalog before meals, because the problem is postprandial. Blood sugars are too high. Or if 4 shots a day is going to be too onerous, especially for someone with type 2 diabetes, switch them to the premix 70-30. And so instead of the basal and 3 shots a day of a quick acting, which is 4 shots, I just switch them to the 70-30 insulin. So you not get 2 shots a day, a shot at breakfast, shot at dinner, which is a little easier, and you get similar coverage. That works good in type 2, doesn't work so good in type 1 diabetes. Next slide. All right, and this pretty much covers the same thing. Next slide. All right, and so this is what I had said. The American Diabetes Association recommends initiation of basal insulin at 10 units a day. Now, that's, like I said, you're going to give it at night. You usually give it after dinner or before bedtime, and you can start with 0.1 to 0.2 units per kilogram per day. Now, in our patient example, she weighs 300 pounds, which is about 136 kilos. And so if you multiply that, you're going to come up with about 13 units a day, which is all going to be given at night. That's why I say you start with about 10 to 20. So it's always safe to start with 10 because the last thing you want to do is make a patient hypoglycemic. A patient that is already on oral agents and maybe an injectable GLP-1, blood sugar's running 200, A1C is like 7.5 or 8. When you start insulin, the critical mistake you do not want to make is give them too much insulin, because now you have no friend, okay? And they don't trust you. So it's better to underestimate than overestimate, because you can always titrate up. That's why they say 0.1 to 0.2 units per kilo, which is roughly about 10 units a day. If it's a patient that has higher blood sugar, say if their sugars are 250, A1C is 9, then you could be more aggressive and start with 20 units at night. But usually 10 to 20, you can use your own judgment. And then I have patients self-titrate up. They'll start with like 10 at night, check their blood sugar in the morning, and if it's still running 180, 200, then increase it by 2 units every couple of days. That's a good frame of mind. It's like 2 units every couple of days until that blood sugar comes down to 120. Now, if you start to go low, then you can always cut it back by 2 units every couple of days. And so you can encourage your patient to self-titrate, because I have them send their blood sugar readings to me with the blood sugars and how much insulin they're taking. So I can see their self-titration, let them make a judgment. Because remember, we're trying to educate patients on how to take care of themselves, okay? It's just like the person that you want to feed, you teach them how to fish. You don't just keep giving them fish, you teach them how to fish. And so they can feed themselves. And so we do the same thing with diabetes. We educate and teach them how to adjust the insulin, teach them how to self-titrate, so they can do that themselves, and you don't get a lot of phone calls on a Saturday night. Okay, next slide. And this slide pretty much says the same thing. There's different algorithms that you can use that are kind of complicated and hard to remember. And again, this is a slide you might want to take a picture or get a copy of this from Jennifer, and it makes a good handout. It's really not a good slide. Next slide. All right, so tips for insulin management. Firstly, start the insulin discussion early. So when I first see a patient, like this lady in the example, she's 300 pounds, her blood sugar is 140, A1C is 7. Well, insulin probably is not in her near future. But just say, for example, if she came in, her blood sugar was 250 and her A1C was like 8.5. Well, we're kind of pushing it, because once you get up around 9 or 10, you're going to need insulin. So I start to mention it early on in case they need it, kind of get it in the back of their mind so it's not a shock if you need to start them on insulin. So I make hints that, we might have to put you on insulin, but if you watch your diet and exercise and you lose 5 or 10 pounds and you take your medicine and do everything I tell you to do, you might be able to avoid insulin. That's possible. But, you might need it anyway. That's a possibility, because, maybe your pancreas is not working. So we'll find out over time. But keep in the back of your mind, you might need some insulin. All right. And we talk about sick day management. What do we do on days that they're sick and can't eat? And usually what we do is cut the dose in half and have them check their blood sugars more often. Traveling, you have to keep insulin cold. Now, the pens, if they're using an insulin vial or pen, the ones that you're not using, you have to keep in the fridge. The pens and the vials, if you're traveling, you keep them at room temperature. The ones you're using can stay at room temperature. They don't necessarily have to be refrigerated. And so, like, I always try to get patients on insulin pens if possible, because it's a lot easier to use. I always tell them that the pen you're using, you just stick in your wife's purse, or just stick in the carry-in thing with your meter, and you can keep it at room temperature. The only thing that destroys insulin is heat. You have to keep it away from a hot window, keep it away from the sun. You can't leave it in a hot car. Heat destroys insulin, but at room temperature on a counter away from the window, insulin is fine for at least a month, especially the pens. You only have to have the ones that are stored for a long period of time in the fridge. So that's important to remember. Once you crack them open and start using them, you got a 30-day count. Talk about adjustments of diet. Physical activity, it's important to talk to them about going to the gym, working out. What do you do? Well, because not everybody goes to the gym every day. Some people go like every other day. So on the days you're going to work out, you want to, maybe reduce your shot. If they're on insulin, reduce the shot. Instead of 4 units before each meal, maybe take 2 units on the days you're going to go to the gym and work out, or even skip it if you're having low spells. So talk to them about physical activity and how to adjust. Lipohypertrophy is rare, but we do see it once in a while. It's kind of a heaping up of fat tissue where you give the injection. It's due to an immune response. Your body's kind of rejecting the protein of the insulin. All you have to do is rotate sites, because usually that goes away within a few days. So just teach them about proper rotation. And they need to check their sugar. I am shocked sometimes that patients that come see me from out of town, they come down from New York, Connecticut, they're on metformin, a couple other oral agents, sometimes even on insulin, and they don't check their blood sugars. I mean, it's actually unacceptable. You need to have a meter, you need to check your blood sugar, and so I get them a meter right away, and our nurse teaches them how to do it. They have these new things now that you've seen, these continuous glucose monitors that, like the Libre or the Dexcom, that either goes behind the arm or goes on the abdomen, that measure interstitial fluid, and they're pretty close to blood sugars. Finger sticks are usually within 10% of the lab, and the interstitial fluid are usually within about 5 to 10% of that. So if you have a blood sugar by finger stick of 100, usually the Libre is going to read about 90, 95, and so they're really a good estimate. You don't have to prick your finger as much. It's really helpful for patients on insulin because we have them check their blood sugar before they give a shot. So if they're on 2 shots a day or 4 shots a day, those little continuous glucose monitors are extremely helpful. Risk of hypoglycemia, it's important to have that discussion early, especially if you put them on a sulfonylurea or if the patient's on insulin, so they know what the symptoms are, feeling shaky, nervous, sweaty. I have a handout that I give patients that talks about how to recognize and treat hypoglycemia. And also if a patient's really brittle diabetes, I usually give them a glucagon kit so they can use glucagon injections if they have a bad episode. Next slide. Sliding scales are, we use those a lot in the hospital when patients are sick and NPO, not eating, throwing up or something, pre and post-op surgery. They're really helpful in the hospital because those patients are not eating. Once patients are eating, the only time I use a sliding scale is usually if the blood sugar is over 200 and you need to take it as a supplement. Because typically if someone's on insulin, they're classically going to be on a basal insulin once a day at night, like 10 or 20 units of Lantus at night, and then a quick acting insulin before meals, either regular, Novolog, Humalog, 4 to 5 units before breakfast, lunch, and dinner. And then I'll add a sliding scale if they're over 200 to take an extra 2, 4, 6 units for every 50 points above 200. So the sliding scale becomes a supplement to your usual dose. Because when patients say, if they're eating and they're otherwise outpatient and normal, and I ask them, well, what insulin do you take? They say, I use a sliding scale. I said, okay. How much is your routine before meal dose? Oh, I just use the sliding scale, which means if their blood sugar is 130 on this scale, they don't take any insulin and they eat their breakfast with no insulin. And so now their blood sugar at lunch is 250 and 300, all right? So you have to educate them. They have to have a pre-meal, even if the sugar is normal at 120, you need a pre-meal dose of insulin before breakfast, lunch, and dinner. And then in that setting, the sliding scale is only an extra amount if you're over 200, for example, if you pick that. So be careful with sliding scales and make sure the patient understands how you're using it. Next slide. All right, so this is some references. You can either take a picture or scan that if you want, or again, Jennifer can get this information to you for diabetes. Next slide. And these are some other references for diabetes. One of the other references that was earlier in the slides about the steps therapy is Dr. Joshua Steinberg. Dr. Steinberg, there's an American Family Physician. The American Family Physician 2019 in February was the article on the steps therapy, and I have a copy of that. And it's cited in one of the earlier slides, the first slide that talked about step therapy, that reference is there. And so you can get that from Jennifer as well. All right, next slide. All right, so complications is what we're trying to avoid. In our example, this lady had new onset type 2 diabetes. She weighs 300 pounds, blood pressure's high, cholesterol's high. And we started her on metformin and we're trying to get her to goal. Next slide. What we're trying to do is avoid these major complications of diabetes, and I always tell patients we're trying to avoid problems with the eyes, heart, kidneys, and feet. Those are the big 4. Eyes, heart, kidneys, and feet. That's what we're trying to avoid. And so with these newer medicines, like the GLP-1s, like Bydureon, Ozempic, and some of the SGLT2 inhibitors like Farxiga, Jardiance, there's lots of advantages because they not only lower the blood sugar by different mechanisms, but they also protect the kidneys and decrease the risk of kidney failure over time. And also they protect the heart. They lower the risk of congestive heart failure over time. So now you have classes of medicines that basically help to prevent or, slow the onset of multiple different complications. I like to start with metformin always, unless there's a reason not to, which is usually because their creatinine is elevated, or stomach upset, in which case we use the extended release. And then my second choice, honestly, is the SGLT2 inhibitors, because they do so many other multiple things. The SGLT2 inhibitors like Farxiga, Jardiance, Invokana, that really would be my second choice, because you're not only lowering the blood sugar, the average person will lose weight, they'll lose 5 to 10 pounds. It lowers the blood pressure about 5 points. But also there's lots of evidence that it helps to slow the progression of kidney disease, decrease proteinuria, and also slows the progression of heart disease in terms of congestive heart failure, what diabetics are more prone to. And in the long-term studies, it decreases the risk of cardiovascular, heart attack, and stroke, and even all-cause mortality is reduced significantly. The GLP-1s to a lesser extent, so that would be my third choice. If a patient is not controlled on metformin and an SGLT2, my next choice, third choice, would be a GLP-1 like Bydureon or Ozempic or Trulicity once a week. Victoza is given once a day, because they delay gastric emptying. They have to help you to lose weight, and they do have some advantages to help the heart and decrease the risk of heart attack and stroke, as well as don't really have much effect on the kidneys, but it's mainly they benefit the heart. So in summary, we're trying to prevent these complications of diabetes by keeping patients under tight control. And the ways we do it is with these multiple medications, which, some of these are new and some are old. But, being able to sort out what do we use first, and then what do we use second, what do we use third, when does insulin come in, all those are in our toolkit to helping treat and control diabetes. Okay, so with that, I'll stop and take any questions. Okay, so if there's no questions, I want to thank you for your time and attention. Again, I want to thank Ruth and thank Jennifer for putting this together. It's delightful. I like being able to show up and just talk and have these ladies do all the background work for me. Thank you so much. And again, thank you from Phi Beta Sigma, my fraternity. This is kind of part of our annual project. We work with Ruth to do some kind of educational thing for either diabetes or some other health situation every year. So thank you for your time and attention.
I have a quick question for Dr. Graham, just a quick question.
Yes, sir.
Yes, you mentioned kidney disease. I was looking into our database for kidney disease, and there are different terminologies. The nephropathy that you mentioned, is that similar to nephrotic syndrome and nephrosis?
No.
No, nephrotic syndrome that's usually another type of cause of kidney disease. It is a cause of kidney disease, but it's usually due to other underlying medical conditions. We're talking about the standard, what they call CKD, chronic kidney disease with proteinuria. And usually with diabetics, they usually have excess protein in the urine. And there's different stages of kidney disease, as you know, stage 1 through 5. 5 is the worst, where patients end up on, kidney dialysis. Most patients have an estimated GFR running around 45, 50, 60, somewhere in that range. And that mid-range is what we're trying to increase their GFR and keep it from declining over time. And that's what these medicines do is, kidney disease has a slow decline over time, and it's just natural that it gets worse with time. So we're trying to flatten out the curve. So instead of it getting worse quickly over a few years, it gets worse slowly over many, many years. And that's the advantage of these medications. But nephrotic syndrome is something different.
Thank you, doctor.
Yes, sir. Good. Well, thank you for your time and attention, and I'll let Ruth and Jennifer take it from here.
Thank you so much, Dr. Graham.
Thank you, Dr. Graham.
What a wonderful presentation. What a wonderful way to present a patient case scenario of diabetes. Thank you again.
No problem. Glad to help.
Now, I have the honor of introducing speaker number 3. Ann Posey. Ann Posey has been with the Behavioral Health Center at Cleveland Clinic in Indian River Hospital since November 2017 and was promoted to the role of Regional Director of Behavioral Health in 2021. Yay! Posey is a licensed mental health counselor in the state of Florida and a nationally certified counselor. She has over 20 years experience in behavioral health care, having worked in inpatient, residential, and outpatient settings. She has a passion for ensuring that those consumers with mental illness get the best possible care available. Ms. Posey has been part of the executive leadership and several agencies that impact the adults and youth with behavioral health needs, including psychiatric hospitals, community mental health, and child welfare, and even juvenile justice system. Since coming to the Behavioral Health Center, Ms. Posey has brought that same level of commitment to change to ensure that the services being provided are the best available. The Behavioral Health Center is a thriving program offering acute care services to both children and adults in Indian River County. Her goal is to expand access to behavioral health across Cleveland Clinic in Florida. Ann Posey, I present to you. You may speak now.
Thank you so much, Ruth. What a grand entrance. So I appreciate you all having me today. I'm gonna talk a little bit about staying mentally fit during stressful times and really talk about the impact of stress and also the impact of the pandemic with a specific focus on people with diabetes. Next slide, please. So why do we need to worry about our mental health? Next slide. So let me give you just some statistics. We know that in America, our stress levels are about 20% higher than the global average. We seem to be a society in America that thrives on stress. Over half of Americans report that they feel stressed out daily, and 63% of US workers feel ready to quit their jobs to avoid work-related stress. We know that people with diabetes are at increased risk of anxiety and eating disorders and almost twice as likely to have depression than the general population. Next slide. So what is it? What is stress? Why do we need to talk about that? Next slide, please. So stress affects everyone. I like to talk about stress as a definition that stress is a strain on a structure. So if you think about a bridge and you built a bridge, there are stressors that impact that bridge. It's an engineering term. So the wind, the sun, boats coming through that might hit that bridge, those kinds of things impact how the bridge is able to function. And not all of those are negative stressors. So if a boat hits a bridge, yes, that would be negative. But a nice sunshiny day, we wouldn't think of as a negative thing. So we need to remember that stressors, they come in both good and bad. A stressor can be a one-time event and a short-term occurrence, but it can often happen repeatedly over time. And people will report that they have routine stress related to pressures of school, work, family, and other daily responsibilities. Now, we can have stress brought about by a negative change, such as losing a job, divorce, or illness, but there's a stress scale out there called Selye's stress scale. I'm probably dating myself because it's a pretty old scale, but it talks a lot about the top 10 stressors, and the top 10 stressors, certainly loss of a job, divorce, or illness are in the top 10, but so is marriage, birth of a child, retirement. You know, all those kinds of things are also extremely stressful events, even though most people would consider them positive events. And then you can have traumatic stress experience such as war, assault, or natural disaster, where people may be in danger of being hurt or killed. And I will tell you that during the pandemic, and I have a slide in a little bit that's going to talk more about that, this pandemic certainly has brought about a great deal of traumatic stress for people in general. Next slide, please. So as I said, not all stress is bad. So stress, there's the fight or flight response, which is where stress signals the body to fight or flee. So when you're presented with a stressful situation, your body reacts, you know, I need to attack this stressor or I need to run from it. And your body doesn't understand positive versus negative. And so what happens is you get an increased heart rate, increased respiration, muscle tension, and increased activity, which gives us all that energy to deal with whatever stressor we're facing. But remember that stress also can motivate us. So I don't know if you all, when you were in school, waited till the 11th hour, you know, to get a project done, and you had all that adrenaline that was going to help you get it done. So we know that stress can motivate us. So if you have to take a test or a job interview or doing something positive, can also be stressful. Next slide, please. And we know that long-term stress can cause us harm. So when you think about that response that your body has, you know, that increased heart rate, you know, you probably have an increased response of food digestion, right, which will increase your blood sugars. All that stuff, when you're under long-term stress, doesn't ever return to normal. So you keep having these spikes of adrenaline, these spikes of your body reacting to stress that never can quite seem to get to the bottom. So the life-saving reactions of acute stress, you know, so if you're driving along and you're running that yellow light and the light turns green on the other side unexpectedly, you see a car, you need to brake. That's that acute stress response. Then you pull off to the side of the road if you're me and kind of shake and cry a little bit and have that recovery phase. With long-term stress, you never get to that recovery stage. So your body is in a constant state of arousal, and that can lead to such things as lead to or exacerbate things like heart disease, hypertension, diabetes, depression, and anxiety. Next slide, please. So what has the impact of the pandemic been on our stress levels? I think this is really, really important. You know, when we went into this, I don't think we thought that 2 years later we would be experiencing the same levels of stress. But we know that nearly 8 in 10 adults, and that's a lot, say that the pandemic has been a significant source of stress in their lives. And 2 in 3 adults say they've experienced increased stress over the course of the pandemic. So you think about that. Think about how the pandemic has caused stress reactions. So people are afraid just of getting sick. People may have lost a job. They may have been socially isolated. You know, the coronavirus itself may not be what's causing the stressor, but some of those residual things that have come out of the pandemic. The other thing that we're seeing is societal stressors have been pervasive in recent years. You know, we see mass shootings, we see a lot of racial tension now, you know, we have climate change issues. The number of things that we are facing as far as societal stressors is increasing dramatically. So nearing 2 in 3 adults say the number of issues facing America is currently overwhelming to them. Next slide, please. So how does stress impact diabetes? So there are a lot of ways, especially during the pandemic, that we've seen the impact. We know that stress hormones can impact blood, there's a little typo there, but blood glucose levels. So we know that when we're under stress, you know, our body is in that fight or flight response. It is creating, increasing our glucose levels in order to provide sugar for energy, and that can, increase people's diabetic response. And we know that then you can see unpredictable fluctuations in blood sugar. So somebody who maybe has been stable on their medication for many, many years, during a time of intense stress may see that they become more brittle and that their blood sugars are going up and down. One of the things that we saw during the pandemic, there are a lot of people who don't really want to advertise the fact that they have diabetes or they're struggling with a chronic illness. And because of the pandemic and the worry of getting sick or catching coronavirus, people have had to open up more about their medical status, and they may find that stressful, that they're having to tell more people or explain, look, I really can't have you come over to a family member, because I'm diabetic, which puts me at higher risk. And that is something that has been really stressful for people. There were some people that I think felt that the reduced in-person contact was helpful. They could control their diet more, exercise more. I am one of the people that my pandemic purchase was a Peloton, so I've been able to kind of, make sure I keep that exercise going. So for some people found it beneficial, but a lot of other people, especially with chronic health conditions like diabetes, felt that lack of in-person contact. They didn't see their doctors as much. So they weren't able to detect issues early or head off some complications that they might have done pre-pandemic. We know that confinement and social isolation can lead to boredom and anxiety, which then can lead to binge eating or unhealthy meal choices. I think many of us can relate to the pandemic 20 that a lot of us were faced with because, it was a stressful time. We were isolated. We didn't have a lot of other outlets. Some people were working from home, which that refrigerator is right there. I find when I work from home, it's much more accessible to me. So we see that was some impact to people with chronic health issues. The cost of fresh food has increased. Also supply and demand, and medication, maybe is becoming more expensive. Everything is a little more expensive. I think we just saw the numbers on inflation. And so that can impact someone who maybe was, doing a pretty good job pre-pandemic of controlling, eating healthy, buying healthy foods, but now is struggling. And people with diabetes were 6 times more likely to have serious symptoms and 12 times more likely to die from COVID-19 than someone with no underlying medical conditions. So certainly the pandemic has had a huge impact on the population of people with diabetes. Next slide, please. I want to talk a little bit about, and I know I'm doing a fair amount of talking about the pandemic, but I think it's been so prevalent. And I also believe that when you meet with people and you meet with your clients and your patients, helping them to understand where they are can certainly be very helpful. Next slide. So this is a slide that comes off the Substance Abuse and Mental Health website. And it talks about the emotional phases of a disaster. So one thing we know about disasters, and we've been through a few, so we've been through 9/11 in my lifetime, Hurricane Katrina. I remember the 2004 hurricanes in St. Lucie County. There's been some mass shootings. So we know that there is a predictable response to a disaster situation. So usually we'll have that pre-disaster reaction where, we heard there was this virus coming out of China. Maybe I ought to be a little worried about it, but it's really not, affecting me all that much. I'll just kind of keep it in the back of my mind. Then we had the impact, slow the spread, 2 weeks to slow the spread, it's here. People were starting to get more anxious. That kind of burst of, I'm afraid, I'm not sure what's going to happen. Those phases last a very short period of time. Then we entered that heroic phase. So maybe a lot of you remembered the heroic phase. I work in a healthcare system, so I can tell you when that was. We were having parades, people were celebrating healthcare workers, you know, people were bringing pizza and donuts, all those unhealthy foods, right? To help us, you know, cope. We felt like we were out there saving lives. You know, we're picking up extra shifts, we're doing extra things, we're stepping out of what we normally do because we're going to beat this together. And that is when people feel very energized and they have a lot of energy and they want to join and be involved. And again, that lasts a very short time. And now and then we honeymoon. So, you know, so we got through that first surge. You know, I feel a little better. I'm going to start taking a few more chances. And then we've entered the disillusionment phase. So the disillusionment phase is clearly where we are now. This has not ended as quickly as we think it is. We see that chronic long-term stress because we're dealing with this every day. And we anticipate that that disillusionment phase will last probably a good year. If not more, because really the pandemic really isn't over yet. So we're still dealing with those surges and those different kinds of things. We're not as kind to each other during this disillusionment phase. You know, I can't remember the last time we had a parade at the hospital. You know, even now, you know, now some people are angry with healthcare workers because of talk about vaccine and how politicized and people feel about vaccinations. You know, I talked with a doctor the other day who was like, you know, my job is to help people. And I went in and all I did was ask whether or not the person was vaccinated. And the response I got was, you know, so hateful that I didn't really know what to do with that. So, so we're seeing that we're in it. This is a very hard time following a disaster. But we do know from other disasters and other things that we've experienced that we will enter a reconstruction phase. And what we will do is our normal in the future is not going to be the normal we had 2 years ago. Think about 9/11. You know, that was a huge lifestyle change for a lot of us. You know, I'm old enough to remember when I did not have to take my shoes off at an airport, you know, where I didn't have these enhanced security screens. And when we first started those and how we thought, how am I ever going to do this? This is such an impact on my life. But now it's our new normal. We're used to it. We know how to adapt to it. And I think we will see that as we move through this disaster, that we'll have some new normal. One of the things I think that is really going to stick around is telehealth. You know, that is something that people were very reluctant to engage in. You know, payers and Medicare didn't want to pay for it, you know, and now I think it's going to be one of our new normals, which is really going to increase access for a lot of people. Next slide. So why do we want to know about these stages? You know, we want to be able to explain to the people that we care for that they're not going crazy, that this is a normal response to an abnormal situation, you know, and that what they're feeling, you know, even they may have never felt this way before, but this is kind of a normal reaction to what's going on in our lives. We also need to be prepared. So knowing that we are going through a disaster and what the stages are, we need to be prepared for what we're going to call the mental health surge. So we know that when we've looked at other disasters, Hurricane Katrina being one, we know the impact on mental health for people who survived that disaster was profound. So psychological casualties far outweigh physical casualties during a disaster, almost 4 to 1. And a pandemic is a special kind of disaster because it lasts a very long time. And I don't know that we'll ever not have COVID. We'll move into a more endemic stage, but you know, it's exhausting. I think all of us are exhausted, you know, by what we need to deal with. And we need to remember that even when the pandemic's over, there are going to be some long-lasting effects that come out of that. Next slide, please. Next slide. So what are the signs and symptoms of stress? I think it's really important to understand this as you work with your patients. and reminding people that stress is not mental illness. There's a big difference. A lot of people don't want to talk about how they're feeling because they think people will label them as mentally ill. There's a lot of implicit bias around that. So we want to be able to encourage people to know what those signs are so that they can be open about how they're feeling. Next slide, please. So people will tell you, I feel like I'm losing my mind. They'll have increased anxiety. They may not be sleeping, waking up early in the morning, crying, feeling depressed. Irritability is a big one. That can be a sign of a stress-related reaction where people are just crankier than usual. People will describe worry and feelings of panic and then overall fatigue. But when they come in to see the doctor or see their healthcare provider, they may say, I think I'm going crazy. What we need to assure them is, no, you're not having, a mental illness, you're having a reaction to stress. Next slide, please. So how do you live with diabetes during a pandemic and under a lot of stress? Diabetes is a full-time job, managing diabetes during normal times. And a lot of our survival instinct is to focus on bigger problems first. So COVID, or avoiding COVID or making sure that we're dealing with those kinds of things. People see that as a bigger problem than their diabetes or their stress management. And so those things may start to take a back seat as they focus on the bigger issue at hand. Next slide. So after talking about what the signs and symptoms are and how we got where we are with our stress-related reactions, we want to talk about how to help ourselves and how to build resiliency so that we can cope not only with the stress we have now, but be prepared for future stressors. Next slide, please. So this is a cartoon that I really like. So, you've got I would assume it's a husband in this scenario, and he says, I'm not a lazy bum. I'm a potential workaholic with extraordinary stress management skills. So, he's there with his bag of chips and watching TV and doing some, in his mind, self-care. Next slide. One of the things we need to encourage people is that we need to learn to tolerate uncertainty and manage worry. So we are in uncertain times. We know that we don't know what's around the corner tomorrow. So we need to learn to manage that. So there's a quote by Mark Twain that I love. He said, I'm an old man. I've had many worries, most of which never came true. So when we think about all those things we've worried about over the course of our lives, some have come true, but a lot of them never came to fruition. So managing worry can be a strategy. Notice when you're worrying, okay? Pay attention to your thoughts, write them down. So keep a log. I'm gonna keep my worry journal. All the things I'm worried about, I'm gonna jot in a notebook, and then I'm gonna schedule a time to worry. So when I jot it down, I can put it aside, and then at 5:15, I'm gonna give myself 15 minutes to go through my list and really commit to worrying about those things. Sounds a little humorous, but it can be a really good strategy for people because putting it aside and allowing themselves a time to worry, they can still engage in that activity because not all worry is bad. We want to have a little worry, right? If people check their blood sugars and it's running high on a consistent basis, we want them to worry about that because we want them to put an action to it. Want them to call their doctor, change, their insulin dose, do something along those lines. What we don't want is for people to obsess. Oh my gosh, my blood sugar has been high for 27 days. I wonder if I'm going to die from my diabetes. And they continue to do that, but they never make that action step of calling the doctor. We need to remind ourselves worrying doesn't really help in and of itself. What helps us is having a plan to address the worry. And encourage people to be mindful, to focus on the present moment. We can't control a lot of the future. And if we can stay in the present, that can be very helpful for us. Next slide. Courage doesn't always roar. Sometimes courage is the quiet voice at the end of the day saying, I will try again tomorrow. You know, so when people are dealing with stressful times, we need to remind them that that's a courageous act, you know, and getting up every day and dealing with the day quietly, not necessarily making these huge, you know, leaps of faith, that is also courageous. Next slide. We need to encourage people to problem solve. All right. So you have this thing that you're worried about. You have this stressor going on in your life. Ask yourself, is this a problem I can solve? Have I had a situation like this before that I've dealt with? And what strategies did I use to deal with? Was there anyone that was helpful when I had to deal with the problem that was similar before? Brainstorm solutions, get creative. I used to do an activity in the hospital with my patients where I would, you know, have them get together in a group and say, you're stuck on a desert island. All you have is 100 bricks, and what's on that island? How are you going to survive? And people would come up with a ton of creative solutions. I remember that I had one woman who said, I'm going to dive for oysters. I'm going to take my bricks and I'm going to find all the pearls I can, smash those pearls and make pearl cream because I want to make sure, you know, that I can keep my skin soft. You know, so problem solving, you know, we can think of a lot of creative ways to solve problems. So brainstorm solutions, pick one, try it. If it doesn't work, move on to a different one. And to stay calm, you know, recognizing, you know, in our lives, we've tried many things. Some have worked, some have happened. We've survived every one of our bad days to date. So encouraging those patients to not stop when the first thing doesn't work. Next slide. So this is, again, related to that slide. It's not easy fitting 60 minutes of exercise into my busy schedule. So today I took 360 10-second walks. All right, so that's problem solving. You know, maybe you don't get that hour of exercise that you need to do in one sitting, but you can break it down into a smaller goal. Next slide, please. Build resilience. And I talked a little bit about this before. Sometimes I get a little ahead of myself, but think about challenges you've had in the past and ask yourself, how did I get through it? What did I do? Who was supportive and helpful? What useful advice did I get for other people? And can any of these things help now? So resilience is learning from our past and building on it and using those tools and techniques we've had before in order to you know, move forward. Next slide. I love realistic optimism. So a lot of times we'll encourage people to be super optimistic about what the future holds. You know, pull up your, you know, just hike up your bootstraps and you're going to make it through it. And you just need to have a positive attitude. That isn't always an easy task. We also don't want to swing the other way with all the negativity. When you look at any problem and you think about what's the worst possible thing that can happen, and that's what you focus on. Realistic optimism really means you really see the problem for what it is, but you recognize that even with really hard situations, that you're going to push through. You're going to figure out a way to deal with the situation. So it's not like being a Pollyanna where you never look at what could happen negatively, but not also staying in the negative like the Grinch. So we want to be realistic. So ask yourself when you're faced with a situation, what's so bad about that? And what's the worst possible thing that can happen? And could I deal with that? And what would I say to a friend? How would I advise a friend? I do a fair amount of self-disclosure on these talks. So I can remember when the pandemic first came out and thinking, you know, oh my gosh, you know, if I should catch this and die, that's about the worst possible thing I think that could happen. And I was a little anxious about that, probably a lot anxious about that, to be honest. So I thought, what kinds of things can I do? So I, you know, to feel like I'm having some action. So updated our will. Right? Made sure all that stuff was updated. Advanced directives were updated. Wrote down all the computer passwords so that my husband could take over if something happened to me. You know, that sounds a little morbid, right? But I felt better you know, saying, you know, I've done all the things I could do. So if this bad thing happens, at least, you know, I'm prepared and not leaving everybody in the lurch. So realistic optimism. Next slide. So the pessimist complains about the wind. The optimist expects that the wind is just going to go away, but the realist adjusts the sails. And so that's what realistic optimism is. It doesn't, the problem isn't just going to go away, and I'm not just going to sit in the problem, but I'm going to adjust the sails and see where I can go. Next slide. Cognitive reframing is another really great thing that we can do, and that's really shifting how we view unpleasant situations. It allows us to challenge those thoughts that give rise to unhelpful emotions. You know, so if we see everything in the negative and then we're anxious and worried, it doesn't really help us. And if we can change how we think about it, you know, see it as a challenge instead of just this horrible thing, then that can be helpful. Next slide. So this is probably my favorite slide. This is my Viking slide. It says, I can't go out today because of the virus. That sounds really weak, whiny, and boring. Try instead, I've sworn an oath of solitude until the pestilence is purged from the land. Sounds more valiant and heroic, and people might even think you're carrying a sword. So that's an example of cognitive reframing. Next slide. Next slide, please. And then, you know, what we always need to do, and I think this is especially true for the people who are struggling with chronic health, health illnesses such as diabetes, is we really need to look after ourselves. So we need to eat healthy, recognize that those high carb, high sugar foods, you know, really don't help us. High protein is really where we need to be. You know, keeping a food diary, those kinds of things, so we have more awareness is helpful. Exercising regularly, so regular exercise, super healthy and super helpful. Exercise releases our endorphins, which are natural antidepressants and natural painkillers. It gives us a way to distract ourselves from the stressors that we might be facing and feel better. The marathon is my favorite race of the Olympics. And if you watch these runners at about mile 25 of 27, they really look like they're gonna die, right? They are not gonna make it. And then they have this burst of energy, which is that, they call it runner's high, that second wind that comes from that endorphin burst. Women in childbirth have more, much higher levels of endorphins than we do on a general day-to-day. So we know exercise can just help us feel better by keeping our mind and body moving, but also by increasing our endorphin level. Sleep is really important, and there are a lot of strategies that you can work with your patient population to help with sleep, with good sleep hygiene. You know, making sure that the only thing, that there aren't TVs and things like that in the bedroom that make the bedroom a place where you don't rest. Making sure the room is comfortable. I invested in a headband that has headphones in it, and I can play meditations and do things like that at night, not to disturb my husband, but will allow me to relax and shift my brain from whatever's going on in the day. I also encourage, if people aren't sleeping, that they get up from bed, go do something outside of their bedroom, you know, read a book, you know, have some warm milk, those kinds of things, so that they don't start to get anticipatory anxiety about sleeping. You know, oh my gosh, I haven't slept the last 5 nights. I really, you know, and they start actually getting stressed out before they go to bed, which then will make it difficult for them to sleep. If you're not sleeping, laying in bed and worrying about not sleeping isn't really helpful. Stay connected with people. You know, has been much more difficult during the pandemic to stay as connected as we'd like to be. And you also want to make sure you're staying connected with positive people. So we all have those people in our lives. Some are friends, some are coworkers, some are even family that are not positive people. And they, even if we're staying connected with them, they can make us feel worse. So make sure you're staying connected with positive people. And then keeping a routine. In times of high stress in highly stressful times, keeping a routine and keeping order in our lives can really make us feel better and feel like we're managing. Next slide. So this is my doctor. I'm prescribing exercise. Think of it as a stress pill that it takes about 30 minutes to swallow. All right, next slide, please. I've listed some self-help books. I don't know if we're sharing the slide deck, but there's some really good self-help books that you can encourage your patients to use. The Anxiety and Phobia Workbook by Edward Bourne, the Feeling Good Handbook, and a mindfulness-based stress reduction workbook. I love workbooks because remember, a lot of what I've talked about has to do with planning and having to, you know, have some structure and some routine, and workbooks can help people to do that. You know, sometimes when people read a book, then it's like, I don't really know how to apply that, but a workbook can help them stay very structured. And a couple of other things that aren't on my slide, I just want to talk about. Encourage people to have a gratitude practice. You know, think about gratitude. What are you grateful for? We can think about all the negative things that are in our lives, but it's hard to be grateful and hateful at the same time. So thinking about reminding people, yes, you know, you're struggling with your diabetes, you have to change your diet, you know, you may have to take these medications, but what is good in your life? Remind me of some of those things. Let's talk about what those are. The other thing is to remind people in high levels of stress that this is not the time not to indulge in some stress reduction activities. So I don't know how many of you watch, do TikTok, but the bones or no bones phenomenon. There's a gentleman on TikTok and he has a 13-year-old pug, and every day he stands the dog up, and if the dog falls over, it's a no bones day, which means you stay in your comfy pants, you keep your lights low, you do good self-care. If the dog stands up, then hey, we're going to go out and take risks and do all those kinds of things. But he's always talking about good self-care activities, right? So make sure you're getting that massage. Make sure that you're, you know, encouraging them, get that mani-pedi, you know, take that nature walk. You know, right now, those are not luxuries, they're necessities for us to be able to manage our stress. Next slide. So our key takeaways, I think from this, are anxiety and depression during this time are normal reactions to an abnormal situation. We need to remember that and remind people that they aren't going crazy, but this is just really a normal reaction to stress. And that using strategies to cope with the trauma that's being experienced is what's going to help us. Rather than just sitting in the stress, what can we do and what kind of strategies can we use? And good health habits will keep us mentally fit. So I believe that's the end of my talk, and I'm more than willing to take any questions. I appreciate your attention today. Thank you.
Do we have any questions or Ann Posey? Okay. I'll tell you, these dynamic speakers that we've had on this morning has disseminated a lot of information. And now, the drum roll, we're getting to hear our last speaker. Her name is Bridget Broxton. Bridget Broxton is a family nurse practitioner with Cleveland Clinic. She has a long history treating diabetes and endocrine disorders, providing patients with counseling on nutrition, exercise, and wound care. She has consulted with other nurses to assist them in managing challenging diabetes cases. Her experience has been shared through various training seminars focused on diabetes education, wound care, and heart failure for staff nurses of home care agencies, assisted living facilities, as well as healthcare students. Today, Bridget will be sharing ideas for helping patients get back on track with their fitness and nutrition routines to better manage their diabetes. I present to you my friend. She reminds me of the old times we had at the health fairs, her and Dr. Graham. So I present to you Bridget Broxton. Bridget. You have to unmute yourself.
Now?
Yes, yes.
So much for that wonderful introduction, Ruth. I really appreciate it. And it does definitely bring back some memories. I was also a part of the original St. Lucie County Diabetes Coalition, along with Florence and Winston, of course, and Dr. James Roberts. And it's just good to see you guys. Thank you so much for having me be a part of this. So I'd like to go ahead and begin by talking to you about nutrition. Next slide, please. Many of us in healthcare are challenged with our patients coming in because of the pandemic. They've experienced a lot of weight gain for various reasons, mostly because of sedentary lifestyle. I mean, many of us were working from home, children even were, doing school from home. Some of us have been stress eating because they're bored or just because that makes us feel more comfortable. So the pandemic, unfortunately, has changed our lives forever. And in many ways, we've had to adapt to our current condition. And the things that we did as a norm, like getting up every morning and going to the gym and working out for 30 minutes, those things were taken away from us, especially during the pandemic times. So it's made us very stressed and we've had to adapt. And so we're going to be talking a little bit about nutrition and exercise today, and we're going to try to give some helpful hints on how to get past what's happening now with the pandemic. Next slide, please. So, many of us are challenged with patients saying, well, I don't need anything. Dr. Graham had mentioned that earlier, and it's particularly if you work in an endocrinology practice, as I do. I work at Cleveland Clinic in Weston, and I work in an endocrinology department. So we hear that a lot. It could be a thyroid condition, it could be a diabetes condition. So we have to be able to get back to the basics in terms of weight loss. And I always like to use the example that it's a mathematical formula. If you want to lose 1 pound a week, you have to reduce your caloric intake by 500 calories a day. So people can relate to that because it doesn't seem like it's an impossible feat. And if you think about it as you're just going to be trying to lose 1 pound a week as opposed to I have 30 pounds to lose, it's a much more achievable goal. So when I say getting back to the basics, I'm talking about the things that we all know, but we don't necessarily do all the time. And we have to try to encourage our patients to do. So obviously reducing caloric intake is key, carbohydrate intake. What makes us gain the weight? Well, it's the carbohydrates primarily and the high fats. So we want to try to avoid the breads, the heavy pastas, of course, the caloric drinks like sodas and juices, etc. And then also avoiding the fad diets, the potato diet or the extreme diets where you're only eating one food. These are typically very difficult to sustain. I mean, they may help you lose some weight initially, but most of us will not be able to stay on these types of fad diets for extended period of times. So in general, we try not to promote any one of those types of diets too much. Portion control, this is common sense basically. It doesn't mean that we cannot have the foods that we enjoy, but that a lot of it has to do with the portion, right? So if we just cut back on the higher carbohydrate foods and try to focus on having leaner foods, lower in fat diet, then we can lose weight or encourage weight loss in our patients by just, promoting portion control. Eating out certainly has been an issue. Initially, when we had the pandemic, we couldn't eat out because restaurants were closed. I mean, who knew that a time like this would ever happen when we couldn't go out to a restaurant of our choice? And then now that we do have access to restaurants, now we're kind of doing overeating perhaps outdoors, into the restaurant scenario. And what does that do for us? Well, if you think about it, what is the real pull for wanting to eat out? Is it that it's just fun to drive in the car and go to a restaurant? It's not really that. I think it's because the foods taste so much better in the restaurant. And why is that? Well, probably because they're not thinking about what they're putting in terms of butter and fat and salt and pepper and spices, things we probably, if we watch them cook the foods, we probably would say, oh my gosh, I can't eat that. But we're not thinking about that. We're thinking about, oh, this is so good. And that's what we're going out to eat. But during the pandemic, stress, we're home, there's nothing else to enjoy, so we focus on eating out, but that definitely contributed to some weight gain, right? So going back to the basics, in the beginning, before the pandemic, we were trying to encourage people to not eat out as much, right? To prepare their foods from home and to try to eat out on a special occasion or maybe on the weekends, but not typically on an everyday basis, because these foods are typically prepared with very high fat content. So that's definitely something that we want to try to encourage the patients to do, not eat out as much, or to try to at least choose very lean foods when you are deciding to eat out. So late night snacking is another issue, particularly when we're looking at weight gain. I know that in my practice, for example, we use continuous glucose monitoring devices a lot. And if I'm looking at a report and I'm analyzing how a patient's blood sugar has been doing over a 14-day period, I can very easily tell what's happening at night, because that report shows that the line is going way up and it goes overnight. And it's just amazing how you can actually see the difference in how a person is eating at night. So definitely try to encourage patients that are eating at night to choose foods that are not going to be containing a lot of sugar. I always say try to avoid fruit and juices and things, ice cream and things like that. So, these are just basic things that we just have to go back to because they actually work. Next slide, please. Useful tips that encourage compliance. There are some tricks to the trade that do help us to kind of increase our satiety. One of the methods that I tend to use, and I don't even realize I'm doing it because I've been doing it for so long, is that I tend to use a very small plate at home, and I'll put the food on the plate, and it looks like you're eating a great portion, but it's not actually, because the plate is so small. So that's one tip. Of course, drinking a lot of water, that's very helpful if you're trying to encourage weight loss. And then eating very non-starchy vegetables, filling up with salads, steamed vegetables, avoiding or limiting sweets because they tend to be higher in calories. And then basically teaching or encouraging patients that you kind of have to earn your treats. So I would never tell a patient you can't have ice cream, because the very first thing they're going to do when they leave your office is they're going to go straight to the store and go straight to the frozen food section and purchase ice cream. It's just the way human nature is. So basically you want to say, okay, what we're going to do is Monday through Friday, we're going to try not to eat those things, and you can reward yourself on the weekend if you feel that you'd like to do that. And that's how they kind of get their own motivation throughout the week to exercise and to do, to eat healthy. Also, one of the main tips is you don't want to buy the foods that you're trying not to eat. So for example, when I have a patient that's telling me, oh, I love chocolate, I love ice cream, or I can't do without having my Snicker bar, or whatever, the first thing I'll say is, well, if you're going to have it, then you're going to have to go out and have one on occasion. But if you bring that home, it's almost as if it's a magnetic attraction. It's kind of calling you right to the kitchen and saying, okay, come and get me. And it's almost like an addiction at sometimes. I have no idea what it's like to love chocolate, but actually, if I can go for months and months without chocolate, but if I know that it's in my home, then I'm going to be drawn towards it. So I always tell my patients, don't buy ice cream. don't like chocolate. If those are the things that you're going to have a difficulty with curbing, then those are not the things that you want to have readily accessible in your home. And then another one of the tips that I like to use is that you should avoid eating until you're full. How many of you, when you were children, your parents said, don't get up until you finish your plate. You've got to finish what you're eating, right? We grew up that way. And oftentimes it's kind of hard to reprocess that and not think in that way. But in actuality, we really don't need to eat until we're full. We shouldn't eat until we're full. And so we try to encourage patients not to do that and to spread out their meals, not to have a large meal at one time, because of course that can really increase their sugars as well. Next slide, please. It's important to set realistic and measurable goals, okay? You never want to say, oh, you got to lose 40 pounds, okay? Because that just seems like it's impossible. So you want to try to start with a small amount of weight, maybe 1 pound a week, which is a realistic goal. And writing this down, you know, actually having someone write it down is helpful, or having patients try to enlist their families to help. Because, for example, in the ice cream example that I gave you, it's difficult for someone to avoid ice cream if their spouse is saying, hey, let's go down to the our favorite ice cream parlor and go get some ice cream tonight, you know. So by enlisting support and letting them know that, hey, this is my goal, so I really need you to help me out here, and that means we just need to curb some of these, you know, trips to the ice cream parlor. You know, those are things that are important because we all need support. It's very difficult if you're surrounded and your family members are not supportive if you're trying to lose weight. So always trying to get support from friends and close family members is vital. Acknowledging your motivation. We're all different. Different things motivate us. For some people, it could be a special occasion, like for a wedding, they want to lose weight, or they want to fit into a certain dress, or maybe they have a graduation, a reunion, you know, a high school reunion or something of that nature. But we all know what drives us, and we just have to try to encourage something that will be meaningful to that patient so that they have that goal in mind. And then, of course, it's important to plan a reward. So when you do meet that goal, then what are you going to do for yourself? And I think that was alluded to earlier when Anne had mentioned, you know, treating yourself, you know, behaving or doing something special for yourself when you actually do meet that goal is real important to motivate us. Next slide, please. So planning your exercise routine, what has worked in the past? So we're going back to the basics. Well, when we were in quarantine, we didn't have the ability to go into the gym. So we had to rethink that. We had to kind of think outside of the box and figure out different ways to get exercise. Not everyone loves to exercise. Some of us love to exercise. Some of us just don't want to have any part of it. So sometimes we just have to try to figure out what does that patient enjoy in terms of exercise. Of course, we know that there's cardio versus strength training or both. And if they're trying to lose weight, you know, cardio is definitely going to help with that weight loss sooner. Although you can do strength training if you do it a lot in continuity there, that you can also lose weight because it does cause you to burn fat. So finding a motivation, seizing the moment, getting started, doing something that's fun. I know for me, I have to have music. There's no way I can run on a treadmill or run or be on the Stepmaster without music. It's not possible. I've tried it. I cannot do it. So, you know, we're all different. And so we just have to find ways to make it enjoyable. And then, of course, knowing our limitations. And this is something that's important with our patients. We can't just encourage them to go out and start running if they haven't exercised for, you know, a couple months. In order to avoid injury, we have to tell them that they should always check with the doctor if they have a cardiac problem, make sure that they can sustain cardio, and also just if they have arthritis, they, you know, they're not going to do heavy lifting, etc. So keep those things in mind as well. This is me in the background here. I actually took a job as a youth coach for a very short time because I've been a diabetic educator for actually over 20 years now. And I wanted the opportunity to see what it was like to motivate patients to exercise. How best could I do that, but actually become a youth coach? And so that was really cool and very fun for me. So next slide, please. Potential barriers to success. Okay. So basically with the pandemic, we had to try to think outside of the box. And not every one of us had access to, you know, a treadmill or a Peloton bike, et cetera. So we had to kind of think about what other things were available to us. You know, initially there was fear of exposure to the virus and spreading it among our family. Even if we were healthy, we may have been worried about bringing the virus home, especially as a healthcare worker, bringing it home to a family member that was maybe vulnerable. So, you know, sometimes because of the pandemic, there's a lack of motivation. It might seem that people might be depressed. A lot of our patients are depressed. I'm seeing it now. It's really difficult because people are tired. You know, the pandemic has lasted much longer than we ever anticipated, and it's really difficult. If it was difficult before, it's 10 times more difficult because people are just basically tired. They don't always know how to get started. They don't have a plan, especially if they've never really been very, very big on exercise to begin with. But it always has to come from within. That's what I mean by when I say no buy-in to the program. It can't be your idea. A spouse can't say, look, you need to exercise, you need to work out today. That never works. It has to come from within. And we, as healthcare providers, practitioners, are in the perfect position to try to encourage patients to do it, because we can come at them from a medical standpoint as opposed to just a physical appearance thing. We can talk about how it impacts their blood pressure, how it can cause cardiovascular disease, et cetera. So we are in the prime position to help motivate patients. Next slide, please. And then sometimes we have patients that have physical limitations. So this is actually a picture of an ergometer. So for patients that cannot, let's say they have arthritis, they cannot participate in some strenuous activities. This is one example of, it's kind of like a cycle. It's almost like a bicycle. They can either use with their hands or with their feet. So, you know, we have to think outside the box. There are patients that just simply cannot participate in some of these things. So this is one example. But if they are able, then lightweight training is great. You know, it can help with weight loss if you do it consistently enough and for long periods of time. It can actually help with weight loss. It can also help you feel great. Walking is a big one. Some people, if they just have their beats on or their music with them, they can walk. Some people love to run. Some people like to bike. Some people like to be indoors doing spin. For people that have arthritis, swimming is another great way to get exercise because there's less, pressure on the joints. And so virtual coaches are also very useful. I can remember going into my kids' rooms and I was so pleased when I'd see them actually with the exercise coach on the phone, and they're in there doing their exercise, you know, things like that. We've definitely have learned to become resilient during this time. So basically, we just have to find the right motivation. It's helpful that if you can find an exercise partner, you know, sometimes even with these online things. But the most important thing is to stick to the plan. Find something or a bunch of things that you enjoy and just come up with a schedule and just stick with it. That's the key, because none of this weight came on overnight. And it's not going to go away overnight, and we just have to be consistent, and that's how the weight loss begins. Next slide, please. So we all know about how exercise can help manage stress, lower blood pressure, particularly for people with diabetes. I mean, I love when I'm able to point out if a patient is wearing one of those continuous glucose monitors, I can actually say, hey, what'd you do this day? Because I can really see the difference. And if I can show them, sometimes I'll even give it to them. I'll give them a copy of the report and say, look what happened on this day when you actually did the walk and your sugars were running like between 100 and 150 all day long. Look at this. And I'll say, hey, take this home and put this on your refrigerator, you know, because it makes a tremendous difference in terms of your blood sugars. And that's probably even easier to see the difference in the blood sugars than it is even with the blood pressure. With the blood pressure, it happens over time, but you can see immediate gratification when you're looking at blood sugars when it comes to exercise. Of course, the feeling of well-being, I know that we all can relate to on the days that we exercise, that you wake up and you get started with exercise, you have so much energy for that day and you feel fantastic. If I could bottle that feeling, I think I'd be a very wealthy person right now, because it is amazing how much more energy. You're not as tired, you feel great. We just have to get to the gym, because once you're there, you feel amazing and you don't even need to be encouraged. So that's important. Strengthening of the heart and the muscles to improve circulation so that we can avoid illness is important. And of course, it helps us to gain confidence. Next slide, please. When we're dealing with counseling our patients about exercise, be patient. For every reason that we can come up with as healthcare practitioners and providers or healthcare workers, for every reason we can come up with they should do something, they can come up with 3 reasons why they shouldn't do it or why they don't want to do it. So we have to be patient with them, and we have to learn to tell them that there's different ways to get motivation. Sometimes they can reach out to health coaches or personal trainers if they have the ability. And during the pandemic, one of the cool things has been that all of this has been accessible online, even with apps. So it's not like you have to even go anywhere. So if you have a problem with getting out, then that's another way that you can access help. They even have like these Zumba coaches or chair exercises. I mean, you name it. You can find almost anything that you want access to if you're looking for it. Next slide, please. So we talked about some of the fact that we can come up with excuses. The most common excuse is I'm tired, or I don't have time, or it's too expensive. I can't afford that gym. I don't even have my job. How am I going to go to the gym? Or your fear of exposure to COVID. I mean, that's a realistic fear. And especially in the beginning when before we even had the vaccines, we certainly weren't going to be thinking about going to the gym. We were afraid to. Physical limitations come into play. We don't think that we can we can start with walking. We don't have to run, we can do walking. Or it's just not enjoyable. Well, it can be. You put some music on, you get going, it can be very enjoyable. So we have to become coaches as physicians, as nurse practitioners, as nurses, etc. We have to really find motivation for our patients. Next slide, please. So in terms of diabetes, specifically with exercise, there are many indicators for loss of control, particularly in relationship to the pandemic. So for example, we see many patients that come now because, we're still in the pandemic. I mean, it's getting better, but we're still within it. So we'll find that we have very high hemoglobin A1Cs. If they do if they get COVID, then a lot of them they go into DKA. So these are things that we've seen as practitioners. We'll find that sometimes they don't have the money, so they stop testing, or they're depressed, so they don't have the will or the desire to even test their blood sugars. They're frustrated with weight gain. They see that they need to lose 20 pounds, and that seems unachievable. So we as providers have to keep our minds open and have a little bit extra understanding, because what we see is that they're missing appointments, they're not taking their medications, but it's oftentimes for good reasons, like they don't have the money to buy the medications, or they're depressed and they just don't see a way out. Oftentimes we have patients that are very vulnerable. They have comorbidities such as renal disease. I see a lot of patients that have had transplants, renal transplants, liver transplants. These patients are extremely vulnerable. They have non-healing wounds. And of course, any infection could potentially cause your blood sugars to go up. So these are all indicators that the pandemic has really taken a toll on our patients that particularly have diabetes. Acute complications, retinopathy, we have to be mindful of that, because if their blood sugars fluctuate from high to low, that increases their risk of retinopathy. So the pandemic in particular has had a huge impact on patients with diabetes. Next slide, please. So what are some of the strategies that we can use now that we're sort of in the reconstruction phase that Anne had alluded to before? We do know that oftentimes it is helpful, even though patients don't see it this way, if we withhold refills or if we give a short-term refills, because we need to get them back into the clinic. I mean, many patients have not been going to the doctor because they don't have the money to, or in some cases, they didn't have the transportation, or they were just afraid to go into the clinic because they didn't want to become, catch the virus from going out, et cetera. So these are some of the strategies that we can use is to basically get patients back, getting their care. I mean, there are patients now that didn't go for their prevention care, and sometimes they're diagnosed with cancer at a time like this because they weren't able to go out and get their colonoscopy, et cetera. So we do have to think about that. I mean, sometimes we're doing a favor to a patient if we just continue to give them a refill. But if we know that that's not getting them into the clinic and they're not getting their labs and they're not, getting the proper care, then that's not really helping them after all, is it? So when they do come in, we download their glucometer, we can look at their continuous glucose monitoring devices, and that can be used as a strategy to encourage compliance. You know that these glucometers are going to become the wave of the future. I mean, there's going to be a time, probably not too long from now, where we won't even see a glucometer because patients are going to, when the cost comes down, they're not going to need to do them. We're going to be able to use these continuous glucose monitoring devices instead. And the information that we can gain as providers from interpreting these reports is invaluable. There's no comparison with looking at the information that we can get from the CGM report as opposed to a fingerstick glucose. No comparison whatsoever. But oftentimes, if I have a patient, let's say, that is on a pill and the insurance is not going to cover the device because they're not on insulin, let's say, for example, sometimes I'll use the continuous glucose monitoring device as a motivation. So I'll say something like, well, you can just purchase this out of pocket, which is not all that expensive. The Libre device in particular is not that expensive out of pocket. So if you just purchase that and you have the ability to see your blood sugars continuously on your phone, then that is oftentimes all they need to follow their diet, because it's almost as if you have someone sitting on your shoulder saying, you're not supposed to have that. So it's like, it's an invaluable tool. So I'll oftentimes use it for that reason, to encourage compliance. And then of course, always, even patients that have had diabetes for years should have access to a diabetes educator, a nutritionist, so that they can get that teaching. I mean, oftentimes patients rely on information that they get from their family members, and it's not always accurate. And so we really should not just anticipate that they know everything that they need to know about how to eat, because that's certainly not the case. There are patient assistance programs. I'm seeing a lot with the patients that I'm seeing in the clinic. A lot of them are having difficulty with affording their medications. So sometimes we have to assist them with patient assistance programs, if you can and have the ability, giving them samples. One of the major tasks that we have now in this reconstructive phase, if you will, is kind of simplifying the regimen. Dr. Graham, my good friends, and he did an awesome job on his lecture this morning. He alluded to it when he was saying that sometimes we have to use the less expensive medications. For example, like the sulfonylureas, like glimepiride or glipizide or glyburide. Even if it's short term, even if it's not the best choice, but let's say the patient say, well, I can't afford my insulin, then sometimes we have to kind of think outside the box, and maybe until they have that gap closed with the insurance, when they get new insurance, we may have to use a certain medication. So you have to constantly be thinking about the cost, because even if it's not the best approach, isn't it better to come up with a different approach that even may be temporary, just to get them over to that point where they're able to get the insurance that they need so they can get the medications. For example, sometimes increasing compliance can be achieved by giving patients combined medications. For example, like Synjardy, metformin and Jardy, and Celequa, which has a GLP-1 and Lantus insulin. So there are different strategies, But of course, all of this comes down to cost. So if a patient can't afford their basal insulin, such as Levemir and Lantus or Tresiba, which can be very, very costly, then sometimes we may have to stand back and we might have to give them a basal of maybe NPH at night, a little bit of NPH. So there are different strategies that endocrinology providers know that can be used. So, you know, we have to think outside the box. Next slide, please. So devices and treatments that foster increased convenience. Of course, this is not factoring the cost factor. If they're able to afford insulin pens, insulin pumps, those are great combination pens, as I alluded to earlier, that have like a GLP-1, like the Soliqua that has both Lantus and the GLP-1 in the pen. Weekly injectables such as Trulicity, Bydureon, Ozempic, et cetera. We've all seen the commercials, Ozempic, right? And the transition to tablets from insulin. You know, these are all things that are not easy, but again, we have to be able to do what's best for the patient. And sometimes we may even have to go back to the old school method. If they can't afford a basal insulin, such as Tresiba, which can be expensive. It's great, but it may be expensive. We may have to go back to something like Humulin 70/30 twice a day, or Novolin 70/30 twice a day. Honestly, at a time like this, I think what's most important is that we get the patient's A1C at goal. Who cares if we're using the old school insulin, if we get the patient with an A1C of 6.9%? Isn't that what's really most important? You know, so again, we just have to keep an open mind and just be prepared to try different things so that we can get through this. Next slide, please. So the effect of COVID on patients with diabetes, we've seen a lot of DKA from it. You know, when the patients get COVID, they oftentimes will go into DKA, even if they weren't at risk for that before. The other issues at hand are steroids. Oftentimes will exacerbate blood sugars if they have pulmonary problems, so they get COVID and they're on steroids such as prednisone or IV Solumedrol, then that can cause their blood sugars to go up. So all these things are factors that COVID in particular has had, and of course the delay in healthcare because patients were not coming in. One of the great things that has come out of this COVID situation is, of course, telehealth and the accessibility of healthcare workers or providers to patients via the internet, which has been fantastic. So that is one positive thing. I mean, we're able, especially in the endocrinology world, we're able to basically do everything almost, except the physical exam, because we're able to see if a patient is able to share their data with us online. We can see their results when they're home. We can see the Dexcom, we can see the Libre results right from the computer. So that's one of the benefits that the COVID situation has increased the accessibility of healthcare visits through telehealth. Next slide, please. So I think we've kind of spoken about the cost of medications and how we can get around that. Sometimes we're having to do prior auths so we can justify getting certain medications that the patients actually need. I think it's very useful to follow the progression of hemoglobin A1Cs for patients to gain compliance. For example, pointing out when they finally get that A1C down to goal of 6.5 or 7, and then just kind of showing, hey, last time you came here, your A1C was 8, and now you've come down to 6. What did you do differently? And that sort of thing. So we really have to kind of look for different ways to motivate patients, and following the progression of A1Cs or fructosamines, which is a 30-day average, as opposed to a hemoglobin A1C, which is a 90-day average. We can use those things to help gain compliance as well. Next slide, please. Next slide, please. So once we control the patients, oftentimes patients come to endocrinology providers because their diabetes is complex. We often will send the patients back to primary care to manage their diabetes, and that can also help with the cost of the visits, et cetera, and the cost of having to see more than one provider. So that's also useful. Next slide, please. If we do recognize that a patient is not compliant, sometimes one of the strategies that I'll use is I'll have them come back at a shorter interval. For example, I'll have them come back in 2 weeks. Or if I have a patient that comes for an endocrinology visit and doesn't bring their glucometer, because they just want to get their refills, then I'll say, okay, well, come back in 2 weeks with your glucometer, and we'll take a look and see how we're going to be able to adjust, because you can't adjust insulins and medications without having some numbers. So that's also important. There is another strategy that we can use to help patients that will not check their sugars are, sometimes you can use the Dexcom or the Libre Pro, which is like a continuous glucose monitoring device that the clinic or the hospital or the individual practice can purchase. And basically it's the same idea, it's the same sensor idea, but the difference is that the patient only wears it for that short term. So if it's the Dexcom, it would be for 10 days. If it's the Libre, it would be 14 days. They would wear the sensor, come in, and they would be able to have this report analyzed by the provider, and it tells a lot of information. So it's also very useful if you're starting a patient on a new regimen and they're not checking their sugars regularly, and you want to have a way to tell whether or not this regimen is working. So that's another tool that can be used. But as I mentioned to you earlier, continuous glucose monitoring is definitely a way to encourage alteration in lifestyle. You can even set alarms on there to increase their confidence. Like if they're afraid of lows overnight, you can have it so that it'll awaken them if their blood sugar drops below 70. So that's also another way to steer change. Next slide, please. So staying the course is the way to gain success, being supportive, giving them access to diabetes educators, nutritionists, support groups. We even had our support group virtual. I mean, that was pretty interesting. I mean, we have to think outside the box. So it's just very important that patients are given that support, and it's the way that they're going to be able to turn things around. Next slide, please. Next slide, please. And this is my final slide. I like to use the analysis of people with butterflies, because like butterflies, people can change and they're able to adapt to the environment and improve their existence with a little bit of support. So for example, you can see that if you're any way familiar with the lifespan of a butterfly, you know that they begin as, well, of course, with an egg, and then they develop into a chrysalis rather. So this is a picture of a chrysalis, and then there's a caterpillar on the top, and then there's a lovely butterfly below. And the analogy I like to use in terms of perspective is this. I went out, I happen to have a garden that I have, because of the pandemic, started a butterfly garden. So I have certain plants within the garden, and in there I have plants that specific butterflies will land on to make different butterflies. So in one particular instance a couple of weeks ago, my granddaughter came in and said, "Nana, there's a very strange looking caterpillar on one of your trees outside." And I said, "Really? That's strange, because I was out there earlier this morning and I didn't see any caterpillars out there." So of course I had to go out there and check it out. And lo and behold, she went on a different tree completely, and she found the picture that you see below, that sort of black and white caterpillar, which I did not even see because that was on a completely different plant. And this is the first time I've actually seen this. I was just delighted to see it. But this is actually a caterpillar that becomes a swallowtail butterfly, which is what you see to the right. So I bring this up because as providers and as practitioners, we have to keep an open perspective, and we might be looking for certain things, but we might be missing other things. So we want to keep ourselves in that position where we are able to keep an open mind, and we can recognize if a patient is non-compliant, it's because maybe they don't have the money to buy the medications, or maybe they're not coming to appointments because they're afraid that we're going to basically lecture them. So I'd like you to think about this in terms of the fact that we've all been very resilient, and it has been a tremendous metamorphosis in terms of what we've come out, how we've come out of this, and hopefully we'll continue to do that. So are there any questions? If not, I will turn it back over to you, Ruth. Thank you so very much.
Thank you so much, Bridget. You know, you stressed a lot of points as the importance of nutrition and exercise. Thank you so much. Well, this concludes our forum, but I have 4 reminders for you before you leave. Number 1, to email Jennifer Harris, if you have not already, your license number for CEUs. 2, there will be a post-form survey will be emailed out, and we would really like your candid feedback. This would be so valuable in helping us plan for future forums. 3, you're cordially invited to the next St. Lucie County Diabetes Coalition meeting, which will be December the 8th, 2021 at 12:15. It's also held virtual. And you're also invited to the next Healthy St. Lucie Coalition meeting on December the 9th, 2021 at 3 p.m. I see where Emily has put information in the chat or links on certain topics that are coming up. We've had some dynamic speakers. Y'all tell you, you all are knowledgeable because knowledge is powerful. And Jennifer, my cohort, would you like to say something? I'll give it to you.
Oh, thank you, Ruth. I would love to introduce Kalita Scott, who's on the call with us today, too. We are initiating a new, I know, right? Initiating a new diet. Well, she's coming to do a lot of things with health equity and all kinds of stuff with the health department. However, she's also one of our wonderful new lifestyle coaches for the National Diabetes Prevention Program. And I'm going to let her tell you about an upcoming program she's starting.
Greetings, everyone. Thank you so much for giving me the opportunity to share this information, especially after this wonderful forum, because it showed how much preventing type 2 diabetes is needed here in St. Lucie County. And I'm so happy to be starting a program that begins in Lincoln Park community. It begins on November 29th, and we'll have 26 classes over about 9 months, where we'll be facilitating conversation to help our residents eat healthy and learn the tools so that they can prevent type 2 diabetes. So we're really excited. We have 2 sign-up sessions that are on Monday the 15th and Monday the 22nd at 2308 Avenue D. I don't know the name of the center, but it's Pastor Henley's Life-Changing Information Center, I believe. And it's right in the middle of our community, and it's accessible to a lot of people. So we're hoping to have some great participation, and hopefully Jennifer can share the flyer and we can share that information if you have anyone who is pre-diabetes and is interested in taking this journey with me. And I'm so excited to kind of just facilitate the conversation and help people get healthier. So thank you. And thank you to all the wonderful presenters today. It really helped me kind of remember the importance with all this information of why it's such a big deal to try to prevent this disease in our community when we can. Thank you.
Yeah, I just hearing Dr. Graham's presentation too on all of the variables and how to mix, and I can't even imagine having to manage that on a daily basis for myself at home. So as much as we can prevent this from happening and starting, the better. So I'm really excited about these prevention programs. We're going to start one now. We plan on killing it with many more classes and getting out in the community a lot more with these. So you're going to get a huge email from me before Monday, including the flyer for Kalita's class that's coming up, the survey link that Ruth mentioned earlier about the forum. We really want to know, how was the time? What did you think about the speakers? Content you might want for another one. I already had like a request for Alzheimer's information and maybe another webinar on that. So different topics you might want to. So we'd love to hear from you. So please take a few minutes just to fill that out. We're going to make it very simple for you. And that's all I have, Ruth.
Okay. I have nothing else to add. We thank you so much for joining us. And we love you. We say goodbye.
Oh, Ruth, can I do one more?
Oh, sure.
I keep forgetting Emily's on the call too. She just did the sign up stuff too, but I'll put this in the email. But we also have a wonderful SNAP-Ed grant where we're doing healthy eating, and I'm gonna mess this all up for Stephanie, but I mean for Emily, but I'll put it in the thing. You want to do it real quick?
Yeah. So I am the SNAP.
Too.
Yeah, I am the SNAP Health Educator here in St. Lucie County with the Department of Health. What I do, I teach nutrition and physical activity classes throughout the community, and my target audience are people who are at or below 200% of the federal poverty level. So I have this really, really great program called Eating Smart, Being Active. It has 9 workshops within the series, and each class we do some educational components. We're a little bit physically active, nothing too strenuous, just to kind of get our bodies moving. And we do a cooking demonstration and a taste testing at every single class, so you can see that eating healthy can taste great. And we always go over how to save money over each lesson as well. So it's going to be cheap recipes that taste great and are great for you. And we are looking for host sites that will allow me to come. I pretty much bring everything we need for the months of December and throughout the new year. We're planning different series. But it's a great opportunity, a great curriculum, and I am so passionate about it and I love it so much. So I'm happy to bring it to the community for everyone.
I'm going to put that in the big email too, so please forgive me, but there's so much great information. I just want to make sure everybody gets a copy of. I know we're at time.
Yes. Thank you, Bridget. Thank you, Ann. Thank you, Edgar. Thank you, Dr. Graham. I know he's already left. We thank you so much. Bye.
Bye. Thank you.
Yeah.